There's so much confusing and conflicting information out there around pregnancy and birth, and none of it comes from the people that are actually in the room. We are Sarah and Catherine, two Canadian labor and delivery nurses with over 4,500 births under our belts.
What if the nurse holding your hand during labor could also answer every question you were too nervous to ask your doctor? Okay, hi everyone. Welcome back to 4,500 Births Later. Today we have Fiona Mattatall, Dr. Fiona Mattatall, specialist obstetrician. In my opinion, one of the best. She was my obstetrician. And she has joined us today to go through some controversial topics out there. Welcome, Fiona Mattatall.
Thank you so much for hosting this important platform and for inviting me today. It's
Thanks
wonderful.
for coming. So, first topic, or I guess we should know who you are, what your background is,
Right.
your education. If you can just tell us a little bit about yourself.
Sure. Well, currently I'm working in Calgary with wonderful people like both of you. I'm an obstetrician gynecologist in Calgary at the Rocky View Hospital. I've been here for 21 years as a staff physician. But going back, I grew up in Calgary and was like a lot of people, I think, who end up in healthcare, a bit of a science nerd in school, and ended up doing very basic sciences. And I did biochemistry. Then I was a researcher for a short time and started doing some very niche, narrow research on one particular protein that bound to platelets, of all things. And I was enjoying the bench research, but I was finding the human part of it a lot more interesting, and was doing some teaching at the university at the time and realized that being in a lab with a lab coat and cells and not human beings was not going to be a good fit for me. So I left the research world and ended up going into medicine. So I did my medical degree. I was very lucky to get into Queen's University out in Ontario. And I was very lucky because I met and was taught by an amazing professor out there who is a medical historian.
Wow.
And so that opened things even more beyond the interesting part of looking after humans and understanding how the human body works, and dove into some of the social construct and the historical construct and the political construct of how we work and how we live and how our health is, and realizing that where we've come from is very important in understanding where we are right now, but also some of the other external factors that are not sciencey but are more social, and how that impacts how we do our work. And I think we'll probably touch on that today. As part of the work I did with this history professor, she challenged me. I did a few research projects with her, and one of them was to go back into my own family history. And I was able to do some research on the only other family member I have who worked in healthcare, which was my grandmother, who was a midwife in Ireland. And so I got to study her life, her work. I never met her in person because she passed away long before I came along. And that sparked an interest in obstetrics and gynecology because I was in medicine and trying to figure out what to do. And I went then from Queen's University out to Dalhousie University, where I did my specialty training and had some really cool experiences out there. And, in addition to learning how to do things like a cesarean section, how to safely look after someone in labor, also got to do some interesting research. And one project I worked on was looking at the impact of a birth plan on how a birth goes. And birth plans were becoming very popular at that time. And I saw some online comments saying that, well, if you have a birth plan, your birth will go better with less intervention. And I was like, oh, that sounds like a good thing. But then you would talk to the labor and delivery nurses, and amazing group of nurses out in Halifax who trained me, and they would all roll their eyes when someone came in with a birth plan and say, well, everything that's specifically on that birth plan that the patient wants to avoid is what they're going to end up having.
Mm-hmm.
I was like, well, there's a disconnect there. Like if online the claims are that this reduces your risk of intervention, but the people who are seeing this on, day after day in the labor room are saying the opposite, which is true. So I decided to do a very weird research project as opposed to, looking at what does this medication do to this? I was like, what does this piece of paper, this birth plan and what goes into it, how does that impact how things go? So that was again sort of that like, where are we, like, what is this social construct of how we do our work and how does that impact it? And so that's always been a thread of curiosity as I've gone through my training and now my work. And I also teach at the medical school, and I teach a chunk of the women's health program at the University of Calgary. And I will often use things out of popular culture or something on Twitter to help teach the students and also throw in a little bit of history so that this next generation are not learning just how to do our work, but reflect on the construct that we're within in how we do this work.
Very cool.
So that's me.
That is very cool. But circling back to your little research study on the birth plan, what were your findings?
So I was fascinated by what I found. So just really simply, I took 2 years worth of birth plans. And at the time in Halifax, if a patient came in with a birth plan, it became part of their medical record. So it was scanned in to their chart and it was kept. So I was able to pull out every birth plan that had come into our hospital in 2 years. And then I went through each birth plan. So I've read a lot of birth plans. And I went down and I categorized, how long was it? What specific things were addressed? So it was really interesting to see what the trends were. And they really haven't changed. This is now like 25 years later. The birth plans really haven't changed. What has changed is they're easier for people to go online and make one, but I don't think they're being made we could use them as a better tool, which we can talk about. Mm-hmm. So I took those birth plans and I was able to identify things about those women who had brought those birth plans, like where did they live? What was their socioeconomic status? How many babies did they have? What was their education level? Prenatal visits. I was able to find another person who had had a baby at our hospital who was almost identical, but who didn't have a birth plan.
Wow.
Because you need to compare like versus like. So I was able to find a match for each one of those patients who didn't have a birth plan, but was almost identical as a patient. And then compared across the two groups, I'm sure all the same questions that you would have. Did they end up in a C-section? Did they need forceps or vacuum? Did they have a postpartum hemorrhage? What was their breastfeeding when they left hospital? Just how did it all go for mom and how did it all go for baby? And interestingly, both were right. Both of the online claims and the nurses were both right in a way, but they were also both wrong because it actually made very little difference. And what I did find is that there's only two things. I measured 30 different outcomes. Only 2 of them were different. One was breastfeeding on discharge, and there was a slightly higher rate of breastfeeding in moms who had a birth plan compared to moms who didn't. And the epidural rates were the same in both groups, even though most birth plans said I did not want an epidural. But in the women who'd had a birth plan, they went through more other analgesic methods on their way to ultimately having the same chance of needing an epidural. And so more use of Entonox, which is laughing gas, and more use of narcotics before ultimately same rates of having epidurals. So everything else was still the same. So like I said, the claims that you would have a lower intervention was actually not true, but the claims that from the healthcare workers that these are the patients that have all the things go wrong was actually not true either. So it was really not that big a difference. But what was fascinating to me at the time was there was data coming out of Australia looking at longer term outcomes from birth plans. And they found that for some patients, having a birth plan worsened their psychological well-being postpartum. And the researchers had speculated that for a woman who has a complicated birth, that if there was a birth plan on her chart, she had a higher scores for depression and anxiety postpartum than a woman who didn't. And their thoughts were that maybe the birth plan was setting her up for an expectation that this is how my birth is going to go, and I have control over A, B, and C. And maybe when that doesn't happen, which we know, working in this space, that it's not always under our control how things play out in the labor room, right? It's just like parenting. Doesn't always turn out like you expect. Certainly hasn't for me and my two kids. But if somebody is maybe set up for an expectation of control and this perfect birth experience and it doesn't happen, maybe there's harm in creating that expectation in the first place. So out of, reflecting on this a lot as I was, researching it in residency, I do not promote birth plans to my patients, and certainly not the online checklists that are out there. I would rather sit down and spend some time and say, okay, what's important to you in this? And maybe use, if they've made a birth plan, use it as a starting point for a conversation around, what do we do that's deemed best evidence right now? Like, delaying cord clamping for a minute. What is really important to them? And so using it as a tool of education and a conversation starter rather than a more rigid plan of this is how it's going to go, because I think we may be setting people up for a trauma experience if their expectations are not maybe realistic. And I mean, I could get into long discussions of why I think this is actually the opposite of feminism. Sometimes we see things that are presented as empowering for women, but they actually are not. And they maybe are disempowering people or empowering them in the wrong space. Sorry, I've gone on a huge tangent, but I spent a lot of time thinking about this and talking with medical students about it. But so yeah, long-winded answer to say my research on birth plans and knowing what's been out there in the research, I don't think they are being used well as a tool right now. But a podcast like you are both putting together with educating people, I think is a far more useful tool on, what are the realities? What do we have control over? What do we not have control over? And maybe seeking for higher quality evidence than somebody saying, this is the way it should be. Or
wow, fascinating. Great research.
It was really interesting. Yeah.
Great research. Okay. I find a lot of times the people who are providing information to the public on an online platform oftentimes don't have the educational background such as yourself and the experience in the labor rooms to give a variety of examples of how different births can go. One person in particular that has no medical background at all made a statement to the world on September 22nd, and President Trump announced that pregnant women should avoid or severely limit the use of Tylenol, citing an unproven link to an increased risk of autism. You, Dr. Fiona Mattatall, made a statement on September 26, 2025 on CBC News that countered that. What was that statement, and do you still stand by that statement today?
If I recall, the statement was that was not good information, for starters. And I was one of many medical voices who, when that came out, decided to step out of our comfort zone and speak to the public. So it was not correct information. Secondly, is thinking about implications of a statement like that are huge, because it's not just avoiding Tylenol, which in and of itself is not safe. What are the implications? So if you have a patient, let's say, who is in pain in pregnancy, and she looks at what she's got at home and says, okay, well, I've got a couple of different pain relieving medications in my, medical cabinet. Okay, I can't use Tylenol. What else is there? And she may go to another medication that is not safe in pregnancy, such as an anti-inflammatory like ibuprofen or Advil. And there are times in pregnancy that is, in fact, not a safe medication for the fetus. So there's that piece of the implication that is dangerous. There's also two other layers to that statement that he made that have big implications. So one was further into his statement. He made a comment about how women should just suck it up, and that a woman who's pregnant and in pain basically doesn't deserve pain relief, which is a very harmful statement to half of the population. There is enough misogyny and history of misogyny in healthcare that we do not need this in 2026. The second piece of it is a bit more subtle, and it's more in the subtext of what he has been doing. And he is not the only politician, but he's certainly the most well-known in doing this. And part of it is, sorry to get political, but who he's hired as the head of the healthcare system in the United States is an anti-science person. And so making an anti-science statement like this puts a rift between, and I'll say the American public, but it does spill over into Canada and the rest of the world, between people who are the experts in healthcare, so nurses, doctors, in pregnancy midwives, and researchers, and the public's trust in that. And it's this constant undermining of that relationship and chipping away at expertise. And it's become quite pervasive. The pandemic was a time where we saw a lot of that. And that was one big statement that directly hits my patients. So that's why I stepped out of my comfort zone to speak with media to try and get the correct information out there to patients. And it was only a week after that statement that he made that I remember there was a patient I was caring for in room 10 on our unit who had developed quite a severe infection during her labor. And she had spiked quite a high temperature. We were giving her antibiotics to improve the safety for both her and her fetus. And we had recommended Tylenol to bring down her fever because she was getting quite febrile, and we were worried that she might, be at risk of seizure or long-term harm. And she refused Tylenol. And I said, why are you this is a basic medication that we use to bring down a fever for anybody who has an infection, and specifically in labor. And she said, well, no, it's not safe anymore. I saw it on the news. And I was just like, oh my God. So here's direct patient harm from a foreign politician making a statement. So there are, like I said, I wasn't the only physician or only science kind of person speaking out against that one statement that he made. But there's enough of this going on, from Trump, but also closer to home in our own province, we have misinformation that goes out. And there's groups of us as physicians who have an interest in science and medicine communication who now work together to try and counter some of the misinformation that's out there. And there are a few really good national efforts in Canada through the Canadian Medical Association to counter misinformation of all kinds. They don't spend a lot of time on pregnancy misinformation, but they do a little bit. I help them with some of the women's health communications and just trying to get good information out there. But it's hard. You feel like a small voice going up against a big voice like someone like Donald Trump. But staying silent is not an alternative. And like I say, I saw that direct harm of one patient in my care because of a statement made by a politician who has no medical training. So that's why I feel like part of my duty as a physician is not only that one-on-one care with a patient, but in that bigger, broader sense, getting into that social construct is using my voice and my privilege that I have as a more senior physician now to be able to speak out and hopefully counter a little bit the bad information.
Thank you.
So, along that note, how do we balance patient autonomy with evidence-based guidance when fear is driving decisions?
That is such a good question, because those three things meet at an intersection that I think can drive a lot of times we have conflict in healthcare, and specifically in labor and delivery. The first piece autonomy means that a patient or like a person comes to a decision with good information and the agency to be able to make a choice in that moment. And I think we are very good at respecting autonomy, and legally we have to respect autonomy in healthcare. You cannot do something to another human without their permission. But one piece that I find is not been good is that person coming with good information always. And so part of our job as healthcare providers is to get a temperature check on, okay, what information are you coming to this decision with? And was that good information? And if not, before we can even go to the next step, we have to make sure that that person is well informed, because part of informed consent is the informed part. And you can probably come up with some thoughts. Like I was going to say vitamin K, but I'm not an expert in pediatrics. I'm an expert in obstetrics. Let's say the use of oxytocin in the third stage of labor. So you both know what that is, but in case some people who are watching don't, is that once the baby has come out, our best evidence says to give a dose of oxytocin, and that reduces the length of time for the placenta to come out, reduces the amount of blood loss that that patient has, and reduces their need for blood transfusion. And that evidence has been around for decades. It is not even controversial at this stage. But occasionally I see a patient come in on the birth plan says, I do not want oxytocin in the third stage of labor. So that one small little choice in the whole journey of having a baby, I would first ask them, where did you get that information from that you were making this choice to not do that? Do you understand that that choice does put you at increased risk for that retained placenta, bleeding, needing a blood transfusion, and then the implications from that? That might mean you're not holding your baby for that first hour because we're now trying to save your life because you're hemorrhaging, and maybe not an understanding of there are places in the world where women would be so fortunate and like asking for this medication that we have easy access to, that women in countries that are not well resourced die from postpartum hemorrhage. And we can prevent that with a very simple intervention. But I find that sometimes where that choice has been made is on that checkoff birth plan on an online website that says, well, do you want oxytocin with the third stage? Yes or no? And they're like, wow, I've heard oxytocin creates problems, so I'm going to check off no, but there's no like diving into what are the pros and cons of that one decision. So that's the one piece of autonomy is I think it's our duty to find out, do you really understand the pros and cons of that? And that's also the job of us as physicians and of midwives who are doing that prenatal care in our offices and trying to get into those discussions before labor and delivery. But sometimes either we don't have time to have those discussions because we're looking at other things. Maybe that birth plan wasn't brought into the office and maybe it just shows up on a chart and then you are both the first ones to see that. So that's the autonomy piece. And the looking at best evidence, and that kind of plays into that as well as discussing with, whether it's a patient or a patient and their support people. Okay, what is the evidence, for and against that? And usually labors last hours. So we sometimes have those opportunities if that's flagged to come in. You both do that frontline discussion with the patient first off. And if there's more questions or we need to get into a more in-depth look into things, we can usually do that, during the labor process before we get to that stage of postpartum. And then the third part of it was fear. And that is something that I've reflected a lot on. And I, in, looking at my practice over 2 decades, I've noticed in the last number of years, probably started before the pandemic, is more patients coming in with fear into our space of, where we look after pregnancies and deliver babies. That fear wasn't there when I started my practice.
Yeah.
Just
Sarah and I have absolutely noticed that as well. Yeah.
And I have some thoughts on why that might be. But I'm curious to ask. Sorry, I'm turning the tables on both of you. But what are your thoughts as to why are we seeing more of that now?
I think partially with the internet.
Yep.
And there's so much information out there. And the algorithms that come along with that. And so people are looking, they're finding something that's kind of in line with where their mind is. And then they find proof, in quotations, that this is the truth and the ultimate. Then they find more information and it just feeds into it. And actually, on my way here today, I had an interesting conversation with my oldest daughter who just graduated from university with her Bachelor of Commerce. And we were talking about AI and even some of the statistical information, if you're working with it and questioning it, and that's not always accurate.
Oh, 100%.
And she was telling me, oh yeah, Mom, it hallucinates. And it's a well-known thing. I'm like, what? Like it sounds so factual, but it's making things up. And sometimes if you press it enough, it will admit that it just made it up.
Right.
Yeah. How about you?
Yeah. What thoughts do you have?
It comes from past medical trauma. This can be a patient's first baby, first time being in the hospital. But because as a child, they had a situation with a doctor, they have this ingrained fear inside of them that they're going to be harmed, they're going to be hurt. Since Sarah and I have started this podcast, I have gone down the rabbit hole listening to a lot of social media women that have had their own birth experiences, but because their birth experiences were so traumatic, and we'll get to this in a moment with the free birthers way. So yeah, I think it comes from past traumas and baseline anxieties, right? A lot of people just carry a baseline anxiety. So I think that plays into it as well.
I agree with both of you. I think both are big factors in this. Speaking to trauma, one thing I've noticed, looking back at how we educate we healthcare workers, probably the same for both of you. I did not learn trauma-informed care in my training. That wasn't even a term that was brought up when we learned how to do our jobs. And when I started teaching at the medical school level, it was not something that we were teaching. We have come a long way, and we've completely flipped our medical education here in Calgary, and a number of medical schools around Canada have. And we very much talk and teach students about trauma and how does so trauma-informed care is where you assume that every patient coming into a space has trauma. That's our default. It's no longer that everybody's coming in, great, I'm going to see the doctor, I'm going to see a nurse, it's all going to be fine. No, the default is actually we assume that every patient coming into this space has been traumatized, whether in a medical setting or outside of medicine, and use language, ask permission, give agency. And so I think this next generation of healthcare workers, whether it's nurses, midwives, physicians, physician assistants, nurse practitioners, this next generation are being trained so much better than our generation was to be more mindful of that. So I'm hoping in time, things will get better when it comes to trauma. But in our space, anybody who's had a trauma like having an invasive test like a rectal thermometer or a transvaginal ultrasound, that can be quite traumatizing. And so being mindful that someone can come into our space with that trauma, but also especially when we are in and around somebody's genitals, is being super mindful that a large proportion of our population have had a sexual trauma in their life, and that we can definitely re-traumatize people in the physical space that we're working in someone's anatomy, but also where there is a power differential. And I think we have been doing a really good job being more mindful of that, even though none of us trained in that. And so I think we're getting to a better place, but it doesn't eliminate that people are still traumatized before they come see us, and that being mindful that we could re-traumatize them. And I look back at my own practice and appreciate that I have contributed to people's trauma, not purposely, but just not being trained adequately in how to not do that. So I think things will get better in that space. But I think a very good first step is to be practicing trauma-informed care. And that's one thing that I've noticed on our unit, that with how we have integrated midwives into the practices that we do, they have improved my awareness of trauma. And I think they have made our whole unit a safer space to hopefully not re-traumatize people who come into our space. So that's one thing I think we've done really well in our unit. The social media piece, I 100% agree. And I have tiptoed into some interesting social media spaces over the years, and especially during the pandemic. And one thing I noticed, I was very active on Twitter for a while, is that I would do these little experiments. Like I'd put the same content for two posts about something medical. And one, I would just do a very bland, neutral statement. And another one would be more shocking, or maybe a visual that was a little bit spicy, or that would emote anger in somebody. And there is no question, when social media metrics they hold on to things that make people angry. It's like it feeds that primitive part of our brain, that flight or fright response. And that goes way farther than something that is calm and bland. So there's the trauma piece, which is absolutely important from that individual. But I completely agree with the social media feeding that. And I think it's not just in healthcare, but specifically in healthcare. There's some real fallout from how social media works. And I think we're starting to learn more about it, even though a lot of us have been dabbling in social media for years. We're starting to understand a little bit about the psychology behind it, and how it has worked, and how it works to promote itself. And I realized this during the pandemic. I was trying to help get some information out, and the main platform I was using was Twitter. And I would communicate a piece of information out. And sometimes I would do like a little experiment, and I'd put similar content in two different posts. And one post would just be very bland, very matter of fact. This is, vaccination and pregnancy. And then I would put out a post and use language that would maybe elicit more of a response from somebody, or maybe anger somebody, or cause a bit of controversy. And then I would sit back and watch what would happen to those two posts. It was like watching like a little race. And there's no question that every time it was something that was a bit more controversial, a bit more emotive, a bit more angering to somebody, it would go farther. And I could see my metrics of how many people viewed, how many reposted, how many responded to posts. And even in that little tiny world of just my Twitter account, could see that emotion drives how the metrics of social media work. And I think we've seen this when it comes to things like claims being made around pregnancy. And the more outrageous it is, the more traction it gets, and the more eyes that see it. And what worries me is, I think about a patient of mine who has a question about something in pregnancy. So let's say going back to the Tylenol in pregnancy, and might go, where do people go for medical information? And then we've got some good data in Canada to look at, especially younger people who are having babies are more likely to go to TikTok for medical information and to answer questions than they are to phone. In Calgary, we've got a 24-hour service that patients can call, or they maybe don't want to bother their family doctor or call their obstetrician or midwife. Late at night, they might just go to social media, and TikTok is the place that people are going to mostly now. But when they go into that space, they may or may not be getting good information. And statistically, they're less likely to be getting good information and more likely to be getting information that is going to elicit an emotional response. And then the way that social media works is that that captures that your eyes were on that one post for X number of seconds. And then it is set up and designed to feed you more of that. And then it gets into a profit system where there are, whether it's an individual or a company uses social media to promote and make money from their posts. And so a person is more likely to see a post coming from someone who is looking to make money off of that misinformation. And so it feeds itself. And then we get into these places where patients come in very poorly informed. And so we were talking about making those, autonomous decisions, but they come in with very bad information. I think that flips it back on us as healthcare providers to see how do we have that not happen? And your podcast is an excellent example of how to get information to people in an easy to understand, way, whether it's listening to a podcast, watching a YouTube video. Like I said, the Canadian Medical Association has been working on going into these social media spaces to provide good information so that we can spread it as hopefully nearly as fast as bad information. But bad information spreads a lot faster than good information on social media, sadly.
Yeah.
So then that leaves us, one-on-one in a labor room with a person who maybe has come in with fear because of something they've heard or they've read. And then they're in the middle of labor and we're trying to overcome all of that in a short span of time with someone who we've just met and they've just met us. And so trying to get some of that trust back is it's a hard job that we have in a very stressful time for people. And I think we do a good job of it, but it's hard and it's physically and emotionally exhausting work that all of us do. But I think it's very important work. So there's my thoughts on that.
Thank you. If you have any questions about what you heard today, please reach out. Sarah and I would love to hear from you. Email us at birthslater@yahoo.com. That's birthslater@yahoo.com. We are here to support you every step of the way. And now for the legal language. This podcast is solely for educational and entertainment purposes. This podcast is not intended as a substitute for professional advice from qualified individuals involved in your prenatal, labor, and postnatal care. Every pregnancy and birth is different, so always talk to your healthcare provider about what's right for you.